I have a couple of questions for you and Nikhil as well, but I'm going to uh, ask you first. One of the questions that has been asked by our panelist, Dr. Indranil Banerjee, and he says that any tips on doing intracorporeal neobladder after a salvage cystectomy? For that matter, should an intracorporeal neobladder be done at all when you're doing it after radiation therapy?
I have to say I have only a very small experience. I did 2 patients after radiation of the prostate. And actually I said him, I don't know if I will be able, we will see. It depends. Some patients, they still have a nice anatomy. They do not have a very big scarring after radiotherapy, others do. And in 2 patients I was able, I saw during the dissection, was still nice. I even could do nerve sparing. And there I had a good outcome also regarding continence. But this is actually more rare than it is frequent. So most often irradiated patients, certainly not an orthotopic neobladder, maybe a heterotopic one, but an orthotopic is seldomly used. Do you agree?
Absolutely. I think, Nikhil, would you like to give your comments on this?
Thank you. I'm obviously following on from Karel's comment. An important thing that we have seen now, is getting more and more salvage cases come through, because probably during the peak of the COVID pandemic, a lot of people had radiotherapy that they shouldn't have had. The 2 things which I have seen, and I've only done one this year, that was a salvage conduit, which I did because the patient did not want a neobladder, was that when I put the cystoscope in the clinic, he had multiple strictures. So I think, post radiotherapy, if someone has developed multiple strictures, especially in prostate cancer radiotherapy in the UK and in Europe, a lot of people will have brachytherapy boosts. So they may get a stricture. And the second thing, which I was a little bit, and I did call Karel during this case, because, I do call him a lot, actually. It was that there was a lot of bowel radiation change too, which I hadn't really noticed in the past, because a lot of the time we tend to see radiotherapy change post prostate, but I think the field in the bladder is broader. And I had to make the conduit 35 centimeters from the IC junction because the terminal ileum was completely irradiated. So I think it is possible. It has been done successfully, but you don't want to do a neobladder and someone who's got multiple strictures. That's a no-no from the word go. And if you have a lot of radiation change to the gut, that might also swing your decision on the type of diversion you want to do. So those were the 2 points. Gagan, thanks.
Exactly.
Fantastic.
Thank you for this extra point, Nick.
Yeah.
Because indeed,
Karel, is it easy to catch a flight from Belgium to UK?
It was, but I took the train. I took the Eurostar train.
Right. Unfortunately, they don't have a train from Belgium to India yet, but one day we'll get there, I'm sure. The next question that I want to ask you is about, you mentioned in your presentation that you were able to send even these complex neobladders, straight to the ward, and they don't need to go to the ICU at all. That's really interesting, because I think a lot of us actually send a lot of patients to ICUs, and only after 2-3 days they get shifted to the wards. How do you manage these? In particular, how do you manage these patients in the post-op period? What tips of ERAS protocols would you like to give the audience which enables you to be able to have these patients out of the ICU on day 0?
So the most important, before we used air seal with low pressure and reduced Trendelenburg position, we were not able to do it. The anesthetists, they did not feel safe after a neobladder, and because this is a longer operation period, they did not feel safe to extubate immediately. So it began actually after we introduced this. And what we are doing now is that they are immediately extubated. The nasogastric tube goes out on the table before they awake, and then they can have small drinks at the first day, but not yet normal food. We try to mobilize them as fast as possible. And all steps of the ERAS protocol that we are using before and that are published is done here. Right? So we use also metoclopramide intravenously, chewing gum, all these things that can help. All these small steps, altogether incremental changes will make it possible. But the thing that really skipped ICU was the low pressure and less Trendelenburg short operation time. That's the thing.
Fantastic. Karel, do you use Alvimopan in the post-op period? Do you have access to it?
No, we don't have access. If you can, certainly do it, because there is less ileus.
Gagan, can I join your question?
Sure. Please, sir, please.
Yeah, both these gentlemen, is a splendid presentation from the times when there used to be in 90s 10% elective ventilation for cystectomies. And I remember we would not get elective ventilator bed from what Karel and Nikhil has presented. My question is, are your ileus or bowel related complications are adjusted for the enhanced protocol or whatever protocols you're adjusting? Because why I'm asking is they become a routine, but the new observers or the participants of this webinar may not go into those fineries that those have become standard practice in your centers. Could you highlight that?
A couple of things, Dr. Bhandari. One is we have a very strict standardized protocol, which starts off right the way through, especially if patients are having neoadjuvant chemotherapy. We did notice a slight increased complication UTI rate in patients having neoadjuvant chemo. But coming to the preoperative bowel prep, so for conduit, it's just clear fluids. For a neobladder, obviously, they require bowel prep. A very important thing which I want to just mention is during COVID, we had no access to intensive care in my center. We had 48 ventilated people in my center at the peak of the COVID pandemic. And basically, my head of ITU said, if you want a bed, it's going to be a matter of luck. That's the situation. Whereas we do have access to a cancer postoperative ITU. And I think your anesthetist has a very important role to play too, to prevent ITU admissions. The reason why I say that is now, because you don't have to do an open incision, they don't really require a PCA or an epidural, which itself can exaggerate the need for a low blood pressure, hypertension, more monitoring with an arterial line. So all my robotic patients, and this is what I picked up from Karel too when he's come to our center very often, is they'll have a tap block, which will be local anesthetic Marcaine based. If they're very big patients, they may need a tap block the next day also. So, a regular PPI, a regular prokinetic, keeping them dry and not overfluid overloaded. Most of our patients on the ward, the length of stay for a conduit is 4 days, for a neobladder it's 7 days. So most people go home on day 4, day 5 after a conduit, which used to be 2 weeks when I was a trainee, in Newcastle. So lots of small steps have led to an improvement in the enhanced recovery protocol. Thank you.
Another question, Nikhil. I assume that semi-long-term and long-term for a conduit, HRQLL, quality of issues remain the same irrespective of the technique used, robotic or open?
Actually, Dr. Bhandari, we've just done a project on something called Iconic, which is a 20-center, multi-center collaboration. The robotic quality of life seems to be a little bit better. We don't know why. Probably the incisions are smaller. The wound-related issues are lower in the context of how they recover post-operatively. But the UTI complication tends to be similar. So I think longer data is required. But there may be a quality of life improvement now in the post-COVID situation because people are going home quicker. They have less pain. Their return to quality of life or return to normal life is quicker too. So, but obviously we're doing more work on the Iconic trial on this.
Thank you. Thank you. Back to you.
Karel, I'm going to be a devil's advocate here. All of us love intracorporeal diversions and it's a regular part of our practice. But you in the first few slides that you showed that the complication rates and especially the high grade complication rates have gone down after the implementation of the intracorporeal diversion program and the orthotopic neobladder that you do intracorporeally. How much of that is actually intracorporeal diversion and how much of that is actually your own increasing experience in the procedure and your team getting more used to it and your post-operative protocols being smoothened out and everybody, recovering fast because of that. So how much would you give credit to as far as the surgical approach is concerned, and how much otherwise?
It's a very good remark. And I have to say, this was my learning curve. So we had a standard open series, or where we did more than 500. And I compared the last 75 open with my first 75 robotics. So this was still with the learning curve included. And of course, if I would take now my last 75, maybe it's even better. But this was just an honest introduction. This is not randomized, of course. This is just changing from open to robotics. And that's what you can achieve if you do it with intracorporeal, in my opinion.
Right. So I think we are not going to let anybody else know that it's not intracorporeal. It's just experience. But yeah, I think it's been a fantastic session. Both Karel and Nikhil, they've really gone to the depths of the cystectomy and intracorporeal diversion techniques. I've learned something really, really new in a lot of aspects today. I really loved a couple of slides by both of you in trying to make this procedure simple. Before I actually wrap up and hand over to Dr. Bhandari, I'm just going to ask one question to both of you. And I would request both of you to answer it separately. For somebody who's just starting off in a robotic, somebody who's a trained urologist, they got a robot in their hospital, they've got a good bladder cancer practice. What few 2-3 tips that each of you would like to give to these surgeons who would like to have a robotic intracorporeal practice, how to go about it? Over to you, Karel, first.
Okay, well, first thing what I would say is have robotic experience in something else before you go to intracorporeal reconstruction. Start with prostates or something. Next thing is have a mentor, and also have a mentor training. So train first, train in a lab where you can make mistakes. Try it first there, then have a mentor that backups you. And last thing is that build a team. Build a good team with your anesthetist, with all the people around it. Show them the videos, that they know what you're going to do. Also the anesthetist, everybody has to know. Also for the ERAS protocols, everybody should be included. That's my advice.
Fantastic. Nikhil, your
thank you, Gagan. And just following on from Karel, I think case selection is important. Don't choose a BMI of 50 who has got T4 disease. You shouldn't really be doing robotically anyway, but someone who's got high volume tumor. And something which I picked up from Karel was when I went and did a dry lab with him in Strasbourg, was follow the principles that you would in open surgery. So achieve a negative margin, get at least 10 lymph nodes out, because bladder cancer is a non-forgiving tumor if surgery is not done properly. If you leave tumor behind, the patient will have cancer-specific mortality. And the third thing is collaborate, speak to others who are doing it, because whenever I go in Perceptor in the UK now, sadly, we can't travel abroad. I've just set up 2 centers in the UK this year. Within 3-4 minutes of seeing someone do some work on the console, you can pick up their experience. But I feel robotic cystectomy and robotic intracorporeal ileal conduit is certainly the peak of where you want to be. And whether we should do some more work on when we should start doing. So, if someone has done 4 prostates and they want to start doing a robotic intracorporeal ileal conduit, maybe that's not the right time. So insight, case selection, collaboration, and keeping all the principles intact is where I would put it, on top of Karel's points, of course. Thanks.
Fantastic points, both Karel and Nikhil. And from my side, I'd like to thank you for having spared your time and your experience in educating all of us. I'd like to thank the Vattikuti Foundation, Dr. Bhandari, Dave, Giovanna, for giving me the opportunity to moderate this session.
Congratulations, Karel, Nikhil, and Gautam.
Certainly, thank you very much for inviting me. Very happy to be here with Nick, my good friend, and it has been a very nice collaboration together that we will keep during our lifetime, I believe.
While I was thanking you for this wonderful webinar with so much latest about it, I can't withhold my comments for the participants because I have always believed that cystectomy and extrophy bladder, two procedures I know with my 5 decades of experience, are natural progression of your surgical skills and competence. They are iconic procedures, so I would refrain from getting excited listening to these experts who made things so simple with their illustrations and videos, and don't jump on your first cystectomy. It is a specialty within a specialty, and you'll have to really work as they have worked, shunning your egos, go to your worst enemy if he's the best surgeon, and learn this, because there are so many points these experts or we don't mention because they become a routine or standard of care in your center, but they do matter in long term. The point which I would like to say that always look at not these outliers who have really produced, like I've been listening to Peter Wickeland, I've been listening to seen Karel's work and all. They are progression, because when Peter Wickeland presented his first 20 cases at Henry Ford way back in 2006, the complication rate was high, and I was wondering why the hell he's doing this for that. And now you see how the things have changed. So still to remind you that the complication, minor and major complication rate after cystectomy are 20 to 40% in published literature. So don't ignore that part. And a word about Vattikuti Foundation. Vattikuti Foundation has one objective, which I have not changed. Mission is how do you improve patient outcomes? And we have taken 2 routes to that. One of them was technology. That technological interface improves surgeon cognition. And that's why we are sold to technology. Technology doesn't mean that it is Da Vinci. It was Da Vinci at that point in time, but we always would believe that technology would, leveraging technology would improve patient outcome. And second thing, what we have done is surgeon education. And that's what we have been talking. And these webinars are part of our mission to educate surgeons. And it's not that, excite them. Webinars would not make you a good cystectomy surgeon or a diversion surgeon, but it would excite you to go deeper into and pave your way to become excellent surgeons. Third thing, recently adding to this navigation plan of ultimately patient outcome is contributions from patient itself. And now we have moved over from our model of B2B, which is interaction with surgeons and hospital. Now we are preparing patients also to contribute their might, so that as a team, surgeon and patients, both stakeholders can hope for an exciting outcome. Thank you very much, gentlemen. This is not the last time I'm bothering you. Thank you, Nikhil, because I just pick up a phone and have a wave, and I call him, and it is done here. So continue doing good work, and we will call upon you. And Vattikuti Foundation is really grateful for educating us and so many of us. And these recordings would be available to all of you. And thank you once again for sparing your Sunday for this activity. We appreciate it very much.